So good morning, everybody. Um, like Nadine said, we're really excited to be here and to talk to you a little bit about what we see as the 5 principles for advancing health equity. Um,
Great.
I'll confess out of the gate, if you can't tell, I have a little bit of a cold, but Nadine's on standby. So if I start coughing or sneezing, she's going to jump in, and I appreciate your patience with me. So before we get to the principles, I think it's always helpful to really kind of level set and just make sure we're launching our conversation from a common space. So first, we know that we're all here at TUDA this year, which is a fabulous event that we look forward to every year. And like Sally did a really great job this morning teeing up, the conference was really developed with a recognition that interdisciplinary, coordinated, cross-sector approaches are necessary to improve health equity and the outcomes that we're seeking for our communities. We also know that, excuse me, we can no longer view each of the sectors that exist in our communities, those sectors that are addressing the social determinants of health, we can't view them as separate from one another. We really have to engage proactively in that silo busting to get everyone around the same table, hence TUDA. And we also have really embraced the belief that evaluating both health and social care data at scale is going to really help us meaningfully move the needle on health equity, and that analyzing the relationship between the health and social care data that exists in our communities will allow us to have some really valuable insight into the overall health of our friends, family, and neighbors. We're all here because we represent some portion of the ecosystem that you see on your screen. And we have some influence and impact on the communities that we serve. It's really impressive to read a bit about where each of you are coming from in the chat. And so hopefully, as we move forward, you feel empowered to sort of speak up, drop thoughts and questions in the chat, and really lean in with your experience and your perspective. Okay, so now that we know why each of us are here representing our organizations and our work, it's, I think, also really important to level set on why this conversation about advancing health equity is important. We know that our legacy system has historically supported health and social services, has long been fragile, wrought with inequities, and plagued by less than ideal individual experiences and outcomes. The COVID-19 pandemic, of course, forced us to confront that reality head on. The system, as it was constructed, at worst, seriously harmed and sadly even sometimes caused the death of individuals throughout our communities. At best, that system really failed to provide what we hope for, that highest quality of care and comfort for the rest of our population. So for all of the pain and trauma caused by the experience of the pandemic, much like Sally and Betsy both identified this morning, COVID-19 has provided us with a really great opportunity. We now have the attention and the public will, and in a lot of cases, the money to begin working differently and making those changes to our system that can help us really achieve the results and the outcomes that we're looking for. If we get this right, if we take advantage of this opportunity and we really lean in, we have a great we increase the likelihood that we're going to see a stronger, more economically viable families and communities. We're going to see a stronger and more stable health and social service system. And we're going to see a society that's moving even closer to realizing its our core ideals of equal opportunity for all, regardless of who they are and where they live. I'm going to pass it back to Nadine for a quick summary of our principles.
Thanks so much, Kelly. So you just heard Kelly really sort of give us that problem, the identity of what our problem or our challenge and the opportunity is for us. And this morning's conversation, I agree with Sally and others, was such a great primer for our now delivery of these 5 principles and what we hope to be really actionable tools and resources for you to take back to your organizations and the work that you do. So a primer on those 5 principles for leveraging SDOH data to improve health equity include, first and foremost, the ability to ensure that communities and individuals that are most impacted have the power, are empowered to make decisions. Second, that we leverage the power of referral data to improve access to social care. And again, leveraging those categories you saw Kelly reference across the social determinants of health. Third, to measure and evaluate. So we only know if the solutions we are attempting to implement are working if we have the ability to measure and to evaluate what we're implementing. 4, removing barriers to data sharing. This is something I think that came up in one of the sticky notes that were shared in our activity in the Jamboard, was this ability to share information and to ensure that we're able to communicate, coordinate, and collaborate across our shared sectors. So we're going to touch on that today too. And then 5, using data to drive action and to continue to iterate and improve our solutions as we head into the future. I'll give it back to Kelly for a deep dive.
Thank you, Nadine. So as we sort of move forward and start to unpack each of these principles, I just want to acknowledge out of the gate that none of this is revolutionary, right? Like Nadine said, we all have a sense. It shows up on our Jamboard. It showed up in the previous breakout session I was in. It showed up in our keynote. These are pretty common sense ideas for how to advance health equity within our communities. What I'd like to do going forward is center on each of these principles, unpack it, but I would love for you all to also offer up either by unmuting and leaning in verbally or throwing into the chat your own experience with each of these principles, what's worked well, what's been a barrier. This is going to be a really great opportunity for us to all learn from one another. Okay, so principle 1, ensuring communities and individuals most impacted have the power to make decisions. We're all very familiar with phrases like client-centered care, a community-driven organization, cross-sector collaboration. These buzzwords and this jargon has really taken hold across all of the sectors we looked at earlier. Unfortunately, the practices that support these phrases becoming reality are a little less common. So if we want to decrease inequity, a good place to start is with those who are experiencing it. What are they seeing, thinking, and feeling? We have to create the conditions in which we ask them. So in terms of collecting information within this principle, we want to be mindful of a few things. We want to make sure that we're being thoughtful about who we're asking. We want to make sure that we've created spaces for a diverse group of clients and collaborators to really feel comfortable to lean in and to provide their input and provide feedback. So once we've created those conditions and we have a sense about who we'd like to collect information from, it's important to give some thought to what we'd like to collect. Now, oftentimes when we're collecting feedback from clients or customers or patients or consumers, however you choose to name your community, we often start by saying, tell us what's going wrong. And I'd like to submit to you that that might not be the most powerful way to begin the conversation. If we are able to flip the script and first ask about what's going right, what are some positive experiences folks are having? Tell us a time when you received the care you needed. What's working well in our practice? What's working well in our services? We can then move from a strengths-based conversation more easily and comfortably into one that can identify gaps or opportunities for improvement. So we know who we're collecting the information from. We know that we want to start by collecting information about them about what's working well, and then move into more constructive criticism. Now we have to really identify when and how we want to collect that information. And the truth is that it's entirely up to you. This principle really should be something that's easily managed within your organization and within your community. So there are likely some natural touch points to collect this feedback. Perhaps it's a post appointment or a post meeting outreach and collection. Maybe it's done on some other time frame, monthly or quarterly. Perhaps the information is being collected via an email survey. If your stakeholder group is connected to technology, perhaps it's a comment box, perhaps it's in person, perhaps there are focus groups or one-to-one opportunities to collect the feedback. Really, the route you choose to collect data within this principle is entirely up to you. The key, however, is to be thoughtful about what you choose and to be consistent once you've made that determination. So we've collected data from the communities and individuals that we're serving. Now we want to take some time to really understand the information we've collected. It's important to really have a targeted group of staff and stakeholders to be able to review feedback and search for underlying strengths and weaknesses, as I pointed to before. You want to make sure that you understand what's going well and what's not. Then within that analysis, you want to work with your group to really map your strengths and your weaknesses. It's possible that some solutions to any equity challenges that are existing within your work already exist in your current practices. After we've collected our data, our feedback, and our information, we've analyzed it, we've looked for strengths and weaknesses, we've started to identify some themes. Now we really want to be thoughtful in creating a plan. We want to have an eye towards what we've learned, what's new to us about the experiences of our clients. And we want to take that information and look towards a long-term strategy. The other piece of our plan is going to be, and this is something that I think is highlighted in our Jamboard a little bit, and it's something that Betsy actually touched on a bit earlier in the keynote. We also want to think strategically about how we're going to communicate back to our community about the information we've received and what we're doing with it. Nothing about us without us, right? We want to make sure that we're creating an environment in which all of those stakeholders, whether they be clients, whether they be staff, whether they be community collaborators, all understand their role and where they fit in the trajectory of our work and our organization. I'm going to pause here for a minute to take a quick drink of my water. If anyone has any thoughts or feedback or reactions to this first principle, or needing if there's anything you want to add or share, I welcome it.
Thanks, Kelly. Yeah, I'll share that Amanda had some great thoughts in the chat for us, that asking and celebrating success also allows the ability to learn from what we're doing right. So it sounds like in right patient safety world that we tend to focus on errors or where we've potentially had oversight or made mistakes. And of course, we need to reflect when that happens, but we also need to reflect, as Amanda has mentioned with great wisdom here, we also need to reflect on our success and what's going well. And I think that this is really a great share out and lends well to this principle of making sure that communities and individuals involved in their own care journey feel empowered and feel that they can share what's going well, but also share that feedback for us around where and how we can improve based on their own lived experience.
Awesome. Thank you for that. All right, so let's move on to principle 2. So here in principle 2, we're really zeroing in on leveraging our own internal data, particularly as it relates to the referrals that we're making on behalf of our clients to other community-based organizations. This is a really great way by zeroing in and looking at this data to better understand the needs of our community as a whole. And perhaps one of the easiest ways to begin collecting some of this data is through a universal screening. So you'd want to sort of pose to your organization, ask whether you use a screener now. Perhaps something like the Prepare screening and SDOH screening, or some other industry-specific screening that you may utilize in your practice. Does that screener work well? Does it give you a sense of the whole person, a snapshot of your client and their experience? Does it set you up well to make referrals for needs that cannot be addressed within your own organization? If so, fabulous. If not, consider a process to evaluate, select, and implement a different or a screener. In order to address inequity, we need to be data-driven, and we need to be able to really zoom out and see our clients for who they are. Once we have a screener and we're set and comfortable with the process by which we're getting sort of playing a role in getting those clients connected to the services they need, we'll want to look at this data to see if we can't identify any themes. And these themes can help us prioritize either new programs and or services that our organization might need to stand up to address issues related to equity, or, and I would challenge you to say something that's probably more likely, is that it'll help to identify the need for stronger relationships with other organizations, either upstream or downstream from where we sit, to ensure that we're starting to really build out that entire ecosystem of service providers. We also want to really think about whether we have a sense as to what the outcomes of the referrals we're making are. If we're screening clients for needs and we're making those referrals out to other community-based organizations, do we know whether or not our clients are getting connected to services? Do we have mechanisms in place to understand if those needs are being met? If not, you may want to collect that? If so, take a look at that data. And again, sort of think about where you might be able to lean in and help address some issues related to equity. If needs are going unmet and referrals are unresolved, we want to identify some opportunities to join community tables to discuss your findings. I'm using the words table and discuss here lightly. Please, based on what I'm saying here, don't let perfect be the enemy of good. Oftentimes, when I pose this thought or idea to organizations, I get a lot of pushback that typically centers around individual professionals not having enough time for another meeting, busy capacity. We don't want to just create more meetings for the sake of meetings to talk about the challenges that everybody's been talking about for years. I got that. You're right. Let's not do that anymore. Instead, let's be data-driven. And if you can't get to a table where these conversations are happening, you probably, and I'm sure do, know people who are at those tables. Make sure you start to share some of your experience and the information you're finding within your own organization to folks who can represent your experience at those community-wide tables, so we can make sure we're building out that ecosystem. Pausing for a quick sip if I missed anything or there's any comments that folks would like to make.
Yeah, thanks very much, Kelly. We did have someone in the chat, Tally. Hopefully I'm saying that name correctly. We're taking a pause here, so would love to hear from you if you have thoughts you want to share.
Hey, yeah, can you hear me?
We can hear you, yes.
Hey, great. Okay, so I just wanted to reinforce the first principle from personal experience and share how valuable I think it is. So I'm transgender, and I noticed that oftentimes in trans health conversations, this identity is heavily pathologized, which reinforces that trans identity is inherently rooted in suffering or trying to get away from this experience of suffering. So I appreciate the strength-based approach, empowering folks without centering people's experiences on what is difficult or not working, starting from a more neutral place, seeing what works well and wanting to continue that. So just as someone who's been a patient who has accessed both affirming and really not affirming healthcare, it is day and night when that approach is used. So I just wanted to say thank you for bringing that up in this space and kind of share that experience.
No, thank you. Thank you for sharing your experience. I think, sometimes we can really get stuck in the business of what we're doing. And things like Principle 1 are really designed to challenge us to just pause and zoom out and remember the heart of what we're doing, which is, helping people. And so we want to create tables and spaces for those people to show up as their authentic selves. Okay, skipping along to Principle 3. So here we're going to turn our attention to measuring and evaluating the data that we've collected under those first two principles. So we have the qualitative and quantitative data provided by our stakeholders themselves, so that external data. And then we also have the data about our clients' needs, the referrals we've made, and the remedies that we've collected via our own internal processes. We want to ensure that we're taking a meaningful and systemic approach to advancing health equity. And we strongly suggest that communities, therefore, are going to need to seek alignment across health and social service organizations on a conceptual framework of how disparities arise and how progress towards reducing those disparities can be assessed over time. So within this principle, we'd like to challenge you to think about a few things. One, community-wide common definitions. An accurate and complete collection of key socio-demographic and non-socio-demographic data. Shared methods for measuring potential disparities. And excuse me, an establishment of a data reporting mechanism that can answer the key questions under consideration. So this may feel like a bit of an overwhelming task, right? Who, even starting at the very beginning, in terms of who are the health and social service organizations that exist in my community? Do I have relationships with them? How do we have a conversation about common definitions? Where does data exist now? It may all feel very overwhelming. It's likely, however, that at least some of this work has already been done within your community through the Community Health Needs Assessment or the Community Health Improvement Plan. So those two documents are really great places to start in terms of evaluating and really taking good stock of the data that you've collected under principles 1 and 2. Excuse me. I suspect, because we are a little bit of a curated group, just being at TUDA today and being in this session today, that everyone is, at least in New Hampshire, already connected to their regional public health network. But if you're not, I challenge you to figure out who that is and get connected with them. They're a really good candidate to help lead and facilitate the conversations around this sort of aligned measure and evaluation of community-wide data, particularly as we think sort of cross-sector and we start to zoom out across all of the social determinants of health. Any thoughts, questions, or feedback to offer here before we scurry on to our last two principles? Okay. So principle 4, this may have a little conversation around it, removing the barriers to data sharing. So the health, social needs, and situations of our clients served by healthcare and community-based organizations continuously change. And we know that there are challenges to achieving the level of health and wellness that we want at an individual or a community level if we haven't created or constructed a system by which we can be responsive and flexible with those changing experiences. Health and social care providers need a way to ensure that they can effectively manage a care journey for a client. They can effectively really take that good whole person snapshot of those that they serve across the historically siloed systems of record. So things like universal screeners and things like tracking that referral data and really understanding what's happening in terms of connecting our clients to services. That data will be super helpful, but it also impacts and includes the need to engage and collaborate with other organizations. So what are the barriers that we are typically seeing and typically hearing about? They fall into two categories. And again, you all experience this. You've put it on some of your sticky notes, and I encourage you to share it in the chat and unmute too in a second and share as well. But really, we hear about concerns around data sharing from the clients themselves. Potential concerns that they may raise are stigma. They don't want to share data that they think is going to potentially cause a negative outcome or negative ramifications for them into the future. They also may not have full awareness of the benefits of cross-sector or cross-service data sharing. They may not know why their primary care provider needs to know if they're food insecure. They may not have that knowledge. And then another barrier that we hear from the client side is a lack of trust in their providers. They don't feel comfortable for a whole host of reasons, providing that level of information to a particular service provider. We also hear about considerable number of barriers that are raised by the staff and the professionals. So one barrier that I hear a lot about is a worry on behalf of clients. This can be a worry in regards to stigma and those negative ramifications. It can also be a worry in regards to having to talk with and engage with their clients in ways that they're not fully comfortable and confident in themselves. I also hear often concerns about compliance with regulation, whether that be HIPAA or 42 CFR Part 2, the federal and state privacy regulations. There can be some concerns and barriers there. And then also there can be barriers related to capacity and logistics for collecting and sharing the data. All of those barriers and challenges are real, but I would submit to you that there is always an opportunity to work through and around barriers. So things like organizational MOUs, ensuring a robust client consent process that won't feel awkward to stand up, particularly if you've engaged in Principle 1 and you've opened the door and you've created that relationship with your clients. Really getting at the table, developing relationships with your fellow providers throughout the community, and thinking through whether there are gaps in the data sharing system and how best to address them together can be really, really an appropriate strategy, particularly if capacity is a concern. Pause here and see if Nadine has any thoughts.
No additional thoughts, but again, as we pause, I welcome anyone to open, take yourself off mute or utilize the chat feature as well to share any additional thoughts, or we can start compiling questions as we approach the fifth and final principle that we're going to talk through. And then of course, bring it home with some call to action too.
All right, perfect. So without further ado, let's dive into Principle 5. So I should have said at the outset, they're numbered, but they're in no particular order, right? So here in Principle 5, we're really wanting to make sure that we use data to drive action. Far too often, historically, we've collected data and done nothing with it. It's gotten dusty. We haven't made any changes. We haven't really implemented or pushed forward to address challenges. I will say that was a generic statement. I'm sure that a lot of the organizations in this room have actually done that. But a really great way to manage the process for making changes as it relates to increasing health equity is to leverage something called the theory of change framework. So a theory of change is a method that explains how a given intervention or set of interventions is expected to lead to a specific development or change. So here you're seeing on your screen the theory of change sort of laid out visually, right? First, we want to understand our intended impact. That's actually a lot of the information and the conversations that we had under the previous 4 principles. Who is our population of focus? Where is our organization going to do its work? And what are we trying to achieve? The theory of change is the answer to the question, how are we going to do it? If we're seeing that we are serving a large population of single mothers, and we have historically been providing in-office care between the hours of 9 and 4. And those services are not helping to advance the goals of the women that we're serving. We'll want to understand how we want to change that. We want to make sure that they're able to come to the appointments. We want to make sure that our no-show rates go down. We want to make sure that when engaging in the service, they're able to be fully present and not being sort of mentally consumed by other challenges or other needs. So maybe our theory of change is that if we change our hours, we'll be able to better achieve the outcomes that we seek. Maybe we provide more services in the community. Maybe we implement home visiting. Maybe we start to think a little bit differently about how we've structured, come up with some theories and test them out to see whether we're able to move the needle as it relates to equitable delivery of services across all of the populations we serve. So as we're coming into the home stretch, I'm going to pass it back to Nadine.
Thank you so much, Kelly. And we got a great comment in the chat from Rudy too regarding barriers to the collection of data, how that data is collected, when the point in time with which that data is collected, how it's made available, and sort of the granular level of the data that's made available. So again, this is a great point too to bring us to our sort of call to action and final steps here. And so we want to, again, bring it home with some support around how you can start thinking about collecting real-time data, start thinking about how to analyze that at your organization level, but really at a community level as well, in partnership with those who you work closely with, and then planning around what your next steps are. We know that this is big. You heard Kelly say that this is a really big challenge. And oftentimes taking that first step is the hardest step toward making a systems change. And so we want to be your partners in making that systems change. We want to support you, whether that's starting small or starting big, in taking that first step around how you hope to move the needle around these principles. And like Kelly emphasized too, right, these are not in any particular order. And we can be your partner in this effort around a pathway forward to better communicate, collaborate, and coordinate among your partners in the community to address health equity together, what a process can be for that, how you can collect and share data in a way that is secure and does empower individuals to better understand how their information will be collected and how that information, more importantly, will be shared among partners and providers, again, to support advancing health equity and addressing where there are disparities in our community. And I'll also give another shout out to the Public Health Association and all of the regional public health networks here in New Hampshire, as well as in Vermont and Maine, as really great resources and starting points, in addition, of course, to working with myself and Kelly at the Unitas team, who can support you in your journey. These folks have really done a lot of great work around community health improvement planning and understanding disparities in and across your communities, and can be, again, a really great starting point for you as you endeavor in this journey. I want to open up the chat because I'm seeing some thoughts here as well. And of course, I want to give an opportunity for open Q&A now as well. It looks like we've got roughly about 10 minutes left in our session, which is perfect. So we welcome your thoughts and your questions here too.
Thank you both so much. This was a great presentation with a lot of good information. I particularly like the moving into action. It's always great to follow up with some steps that people can take. And as I said, we're open for questions now. Feel free to raise your hand and come off mute if you'd like to participate that way, or enter in any questions in the chat. And I can start us off. Touched on it a little bit, and some of the conversation in the chat did as well. But the struggle with data that ends up being, you might have data on smaller populations, but it could also be suppressed so that you have a bigger number to actually to work with. But in suppressing the data, then you lose what's happening with those smaller populations. So what do you do when the data just isn't available? Like, how can we work with the data that we have and recognize its limitations without creating bad programming or policy.
I think it's a really great question, Heather. And this is really, I think, one of the biggest uphill battles and challenges for us. And I often hear from organizations what they're doing at a localized level, either within their organization or a small coalition, or what we refer to often as a micro network of partners and providers. Folks are probably very familiar with the integrated delivery network model that we had in New Hampshire that was really driving a lot of coordination and tackling some of these big questions and challenges. And so I sort of will answer this with, we have to utilize what we know is available, but I think we're oftentimes blind to what is available or what our partners in the community are doing around collecting and sharing data. And so I would sort of answer this with another call to action, which is, find out a little bit more about what your partners in the community are doing. What type of data are they collecting? How are they collecting that data? Are they leveraging partners who are supporting them in collecting that data? Do they have resources and tools that they leverage? The Unite Us care coordination platform and tool that Kelly and I support alongside a number of partners in New Hampshire is a repository of data and another tool in the community that can be supporting you in collecting data. And we're able to provide that in the aggregate at a community-wide level, with some really great rich data that oftentimes, in my experience, really goes underutilized. And so, it's why one of my call to action was, of course, to reach out to us to find out how or if we can support you in your path to really think a little bit deeper about how you're collecting and then how you're leveraging that data. Kelly, anything to add?
Yeah, I'll just add another opportunity to leverage small pockets of data. And it actually goes to one of the things that I mentioned under one of the earlier principles about aligning definitions and the way that you're collecting and thinking about data is that oftentimes organizations that receive funding from common places have common data collection and reporting requirements. And perhaps there's an opportunity to pool that data because it's for the most part going to be apples to apples to get a better, more comprehensive snapshot that sort of gets you away from some of those challenges you were alluding to, Heather. In my previous role, I used to do a lot of work with SAMHSA funding. And within SAMHSA, there's standard KPIs that every grant needs to track and record and understand. And so there's an opportunity there to leverage that data to understand who in your community is being funded in that way, and to have a conversation around what that data can tell us at the community level.
Thank you both so much. Those are really helpful responses and answers. And yeah, I think pooling data, looking to see what sources exist, going to the populations that you're trying to learn more about is really helpful. Questions from others in the audience? And again, feel free to raise your hand or enter it into the chat.
We'll be sure to flash up the final slide too with our contact information. So should you have questions after today's session, you can reach out to both Kelly as well as myself with any additional thoughts or questions or feedback. And I'll also be part of a roundtable discussion this afternoon at 2:15. So you can also catch me there. If you are still participating this afternoon, I'll be available there for any additional thoughts or questions or feedback this afternoon as well. And for those who have not seen it, Joe Porter, thank you so much, shared a great link out to some claims data that is available publicly. And that might be another great source to start with.
Well, thank you both so much. Really appreciate you putting your contact information up so folks can reach out. I know I'm often one of those people that needs to sit and chew on things a little bit before questions come up, or actually, put this into action and then see what's questioning for me. So really appreciate you both being here, and everyone in attendance in the audience. I do believe we're going into our lunch break next. So I won't hold anyone up from getting lunch or moving around and getting outside. Thank you all, and we will see you back here after the lunch break.